Okay, welcome everybody to our session on global initiatives to eliminate HIV stigma and discrimination. My name is Umunyana Rujeje, and I'm the head of human rights at UNAIDS. You're all welcome. Please come through. And again, if you would like to enjoy the comfort of these white chairs, please come forward. So I would like to also start by thanking the International AIDS Society, IAS, that has sponsored this panel. We're very excited to have the Global Network for People Living with HIV, GNP Plus. They are making up this wonderful panel. And we are very pleased to be talking about the issue of stigma and discrimination in relation to HIV. We know that we know the path to end AIDS. We know that we need to allow communities to lead. Communities must lead, and we must make sure that the enabling environment for them to lead organizations, for them to do their work in countries must be done. And it's all of our responsibility to do so. We must ensure that we are addressing the inequalities that are causing barriers to ending HIV and AIDS. We know, for example, that there are policies and laws that continue to discriminate against people living with HIV and key populations. We know that dismantling those barriers is the path to ending AIDS. We've made progress, but there's still much to do. And addressing stigma and discrimination in relation to HIV is one of the things that is very key. And the communities must lead us to do that. There's much work that GNP Plus has done in terms of gathering data and ensuring that the work of communities is recognized, incorporated into government data, and that interventions take account of what communities need. So I would like to invite our panelists to share this information with us. It's very exciting to have the Stigma Index report that will be presented by Omar Sarif, who is from GNP Plus. Sibongile Nkosi is the co-executive director of GNP Plus, who will also be sharing with us the global consensus on HIV stigma and discrimination, and Dottie, who you all know, also from GNP Plus, will be talking about the global initiatives, in particular the global partnership on action to end all forms of discrimination, stigma and discrimination. So I'd like to start by inviting Omar. He's got some lovely infographics that he's going to share with us and take us through that data so that we understand the basis on which we are making demands around interventions and programs to end HIV stigma and discrimination. Thank you.
Check, check. A very good afternoon to everyone, and thank you so much for joining us this afternoon to hear the work that we've been doing from global level, but also in partnership with our community partners at country level around HIV-related stigma and discrimination. I would like to start our afternoon by sharing the key findings for our first ever global report of PLHIV stigma index that we completed last month. And this is the first opportunity for us to be able to share this important information through the world. Can I have the slides? So next. So for those who's not really familiar with PLHIV Stigma Index program, PLHIV Stigma Index is a community-led research that is led by people living with HIV groups. And the purpose is to document our experience in relation to HIV stigma and discrimination, and gather the evidence and use it for advocacy. So stigma index has been around since 2008, but in 2020 we start rolling out the standardized methodology. And why we use the standardized approach? Because by using the standardized approach, it will allow us to increase the comparability across time, but also across setting. I think this is a very important aspect of research that will allow us to track our progress in terms of eliminating HIV-related stigma and discrimination. So the global report that we developed, can you come back to the next slide? Sorry, to the previous slide, thank you. So we are using data sets from 25 countries around the world. Out of the 25 countries, 12 countries are in the Africa region, including Angola, Benin, Burkina Faso, Cote d'Ivoire, Ghana, Kenya, Lesotho, Mauritania, Nigeria, Togo, Zanzibar, and Zimbabwe. And all of these 25 countries has been using the standardized approach in their implementation, and that's why we include them in the development of this report. Next slide. So the profile of the respondents that we participated in this process, there are more than 30,000 people living with HIV took part of this study. And out of those total number, 35.2% belong from key population living with HIV, including 15% from sex workers living with HIV, 12.7% from people who use drugs living with HIV, 12.3% from gay men and other MSM living with HIV, and 5% from transgender living with HIV. From sex assigned at birth, there are 46.1% male respondents and 53.9% female respondent, with the average age of 39 years old. Before I go to the next slides, even this is very important for us to understand that even this is a very scientific process, and we have a lot of statistical figure. This is actually the story of people living with HIV. Our resilience, our suffering, this is all it's about. So in the next few slides, I'm going to share the stories from community on their experience of HIV stigma and discrimination. Next slides. For your information, we include an audio recording, so hopefully we can play it. This is not the actual recording of the respondent, but we translate it to audio for easier use. If you hover under the speaker sound, there should be a play button.
So if there's an event like my husband has told everyone that I'm HIV positive. So if there's an event like a Muslim, my husband has told everyone that I'm HIV positive. So if there's an event like a Muslim wedding or baptism, I'm not invited. I'm excluded from all activities related to food preparation. And if I go, other wives don't want me to eat with them.
Can you kindly
My
enough to play
husband
it
has
once
told
again?
everyone that I'm HIV positive. So if there's an event like a Muslim wedding or baptism, I'm not invited. I'm excluded from all activities related to food preparation. And if I go, other wives don't want me to eat with them. Only my family accepts me. In my husband's family, I'm excluded. I'm singled out and I'm insulted by those other women.
Next slide, please. So the story that we just heard is a story about isolation. a lot of our community friends, they were excluded, they were isolated from community gathering, from community event that lead to isolation. And this is really, uh, manifestation of HIV-related stigma and discrimination. The story that we just heard was backed up by the findings from our report that nearly a quarter of respondents experienced HIV-related stigma and discrimination in the past 12 months. Out of these, almost 1 in 3 experienced discriminatory remarks or were subject to gossip by family members or other people surround them. On the case of key population living with HIV, this number even grow significantly. With from MSM community, there are between 29.3 on MSM living with HIV, 26.9 on sex worker, almost 30% on transgender living with HIV, and around 23% of people living with HIV. Again, this again, solidify what we have been, hearing, what we've been experiencing so many times as people living with HIV. Next slides.
At the beginning of the disease, I almost committed suicide because I didn't know how to live with it. Everyone in my family turned their backs on me. I was a disgrace to my family and everyone avoided me. I had no support. I didn't know who to turn to until one day I discovered community life.
So the story that we just heard from Benin showcase that internalized stigma is a big problem among people living with HIV. Over 84% of the respondents agreed that they feel ashamed with their HIV status, and this has been used in the global AIDS monitoring as a key indicator. And currently, we are at 37.6% in terms of internalized stigma. For your information, key indicators under global AIDS monitoring, the data source is from stigma index. And one of the reasons that we are using standardized methodology at country implementation is to allow that data to be used to inform a GAM report from each country. But it's important to note from that story that internalized stigma can be tackled by providing psychosocial support through PLHIV self-help group. And we've been seeing a decrease in terms of investment for PLHIV support group, while the story really showcased the importance and the needs of a strong PLHIV support group to make sure that they don't feel alone. They can share their bad experience and found strength together. That's the strengths of a positive support group. I am here before you because I'm benefit from PLHIV support group, and I'm very sure a lot of our friends from PLHIV community have the same experience on how important is PLHIV support group. Next slide, please. Internalized stigma also give a negative impact towards treatment adherence. Over a quarter of respondents said they have ever interrupted or stopped their HIV treatment. And those are because of the fear of a health worker would treat them badly or disclose their status without consent. And this fear is not coming out of the blue. This fear is coming from the traumatic experience that their friends experience, because the study also show that 16.5% has actually experienced bad service or low quality service, stigmatized and discriminatory service from healthcare worker. So this is not only about fear, but fear that was caused by traumatic experience. And the finding also show that the most common HIV-related stigma reason in the past 12 months is that 30, almost 35% of them worried that someone would find their status, and 23.3% were not ready to deal with their HIV infection. Again, this is showcase the needs for a strong support for those who just find out their diagnosis, to make sure they're ready to deal and face and continuing their life with HIV. Next slides. The findings on HIV, I think the next slides, please. Thank you. So on HIV disclosure, there's a mistake. It's not 1 in 6, but it's 57%. So it's more than half of respondents indicated that they let one of the person listed below about their status. And most of them feel that those who were close and they disclosed their status to were very supportive. While if they disclose their status to those who are not really close, the supportive attitude is not that high. It's only like 18.8%. Next slide.
I decided to stop going to this health center because during my delivery, the midwife didn't help me because of my HIV status, which meant I lost my baby. My mother-in-law, once informed by my husband, asked her son not to touch me again so as not to become infected. In the end, I went back to my parents' house.
Next slide. So this is the story on stigma.
I decided to stop going to this.
So this is the story about stigma and discrimination in healthcare setting. Our findings show that 1 in 8 face HIV-related stigma and discrimination from the healthcare worker where they receive their HIV care. And this is coming from the past 12 months. This number doubled when they seek care for non-HIV related services. And when it comes to people living with HIV from key population background, the number even bigger. With transgender people living with HIV is the one who most experience stigma and discrimination from a healthcare worker with 31.7%. Sex worker living with HIV with almost 30%, and people who use drugs with almost 28%. Next slide. So our findings on human rights violation show that there are almost 8% experience forced testing, and most of the time this forced testing was happen when they want to access healthcare services, when they want to apply for job or to get a pension plan, when they want to obtain visa, or if they want to travel to other countries. They also experience forced testing when they're trying to get medical insurance, and also when they're trying to get higher education or register in a school. Next slide. The good news is there are quite a lot of initiative from our community that seeks redress for this violation. Our study shows that 73% of our respondents that experience human rights violation sought for redress. 20% filed for complaint, and almost 20% contacted their local networks to and ask for support to address the experience that they have in their settings. Next slide. So one other aspect that is also important and is one of our key findings is on intersectional stigma. And I think it is quite clear that key population living with HIV experience multiple layer of stigma. Our report shows that transgender people living with HIV experience the most intersectional stigma with almost 50%, and soon after there's a gay man and MSM living with HIV with 40.5%, people who use drug with 27%, and then sex worker with almost 26%. So these are the stories that we documented in our global report. And we really see the importance of using these findings and to inform the program decision, the program design, but also to inform the policy development. And further, we really see the big possibility to use this finding as a baseline as we move towards 2030 and to end HIV-related stigma discrimination. With that, I thank you for listening and happy to respond to any question. Thank you.
Thank you so much, Omar. I think it's so important for us to hear what the data says, the rigorous research that is in our communities, and also to be able to tell the stories, because the stories are part of the data. It's the data story. And it really ensures that we're able to make the connection and show exactly where the inequalities are, how gay men and men who have sex with men are disadvantaged and discriminated against, how sex workers are discriminated against, and people living with HIV in all areas of their lives experience stigma and discrimination. So now we're going to hear about one of the initiatives that is intended to provide technical support to countries to address these very inequalities. Dottie?
Thanks, Umanyana. Good afternoon. So the work that my colleague Omar just presented is the data. And so I'm here to introduce to you and share with you the work that we do under the Global Partnership for Action to Eliminate All Forms of HIV-related stigma and discrimination. This is where we take that data and turn it into action and turn it into advocacy. So the global partnership, which is what we call it because the whole phrase is a mouthful and we just call it global partnership, is a collaborative effort that GMP Plus has the privilege to lead as a global advocacy communities lead in the entire program. Can I have the next slide? Thank you. So we all know this is something that is not new to us, that stigma, discrimination, and criminalization are impediments to the HIV response. Data that my colleague Omar has just shared is very clear, and it is evidence that we can use in our advocacy. For instance, in sub-Saharan Africa, between 10% and 40% of gay men and other men who have sex with men avoid visiting healthcare facilities due to fear of stigma. 32% of sex workers do not know their HIV status because they're fearful of the stigma that is related to accessing services in healthcare facilities, as well as the fear of disclosure to their partners and other community members. HIV criminalization also undermines the efforts around treatment, prevention, care, and support for people living with HIV due to fear of stigma and discrimination, also towards the disclosure of their HIV status to their families, to their communities, to other society members. And then overally, as we're looking at inequalities and wanting to address inequalities, 10 to 30% of women make up a significant proportion of communities of persons who use drugs, and that number increases if they are HIV positive. Next slide. The data also shows us that by addressing societal enablers, by using the tools that are available to us, such as the global strategy to end inequalities to end AIDS for 2023 to 2060, and using also the global report in addressing inequalities that was launched this year, we can actually save 2.5 million lives by 2030, and we can avert 1.7 million lives from AIDS related deaths. Next slide. This is where the global partnerships plays a critical role. The origin of the global partnerships came from the PCB NGO delegation, where there was a firm call to the governments to translate those commitments into actions. Our governments have commitments around political and human rights in addressing stigma and eliminating stigma and discrimination, but these are not being felt at country level. We also needed the programs to be scaled up and to strengthen the synergies and the partnerships that are happening at country level, and also to use evidence-based data such as stigma index to inform the policy and the programming, and to support the accountability and measure progress all at country level. Global partnership came together with UNAIDS, UN Women, UNDP, and the Global Fund and GNP Plus. These 5 institutions form what is called the conveners group of the global partnership. If you look at the settings where stigma and discrimination is if you look at the settings where stigma and discrimination is prevalent in amongst communities, which is also captured in our stigma index, we have healthcare setting, workplace setting, education, humanitarian settings, justice settings, and communities. Together with the co-conveners, we work with technical partners who can be able to help us at country level to address some of these issues. For instance, ICW East Africa and UN Women are our key partners and technical leads in addressing stigma in community settings. UNDP and the HIV Justice Network are key partners in addressing stigma and discrimination in the justice setting. ICASA and the World Food Programme are the key leads and technical partners in addressing stigma and discrimination in humanitarian settings. UNESCO and Athena Network are addressing in the education settings. The ILO and ALMAR Network are addressing stigma and discrimination in the workplace setting. And finally, WHO and Asia Catalyst are addressing stigma and discrimination and providing technical assistance in the healthcare settings. Next slide. Up to date, we have 36, and I want to say, as of 1st of December 2023, on World AIDS Day, Ghana joined Global Partnership. So this number is increased to 37. Our global partnership countries spread across the globe in all regions, and we continue to advocate, and GNP Plus continues to work very closely with the co-conveners group to increase visibility and share the information, knowledge, and the work that's happening in country level to urge countries to join the global partnership in eliminating all forms of HIV-related stigma and discrimination. Next slide, please. I want to talk about what's happening in this continent and the work the GMP Plus is supporting in the countries and the activities that we are undertaking. In Uganda, they're addressing the workplace settings. The network of people living with HIV in Uganda, NAFOFANU, have worked to address stigma and discrimination in the workplace. They have developed a manual together with the Uganda Federation of Employers to train employers in Uganda, and this has been adopted by the National AIDS Control Council in Uganda. And at this moment, we are advocating to work with the International Labour Organization so that then this can be a module that is replicated to the other 37 countries. In Ghana, NAPLAS Ghana are working on internalized stigma with mothers living with HIV. And as a result, they have demonstrated a methodology of addressing self-stigma. I want to acknowledge some of our partners from NAPLAS Ghana who are in the room, and that we are very proud and appreciate the commitment that you have and the work that you are doing in Ghana to address stigma and discrimination. In DRC, the Rela are working to empower women living with HIV and have trained 60 women who are now focal people that are working with the public healthcare setting to address stigma and discrimination for mothers who are living with HIV and wanting to access PMTCT services. In Cote d'Ivoire, they are working in the community setting with training faith-based leader in addressing HIV-related stigma. The Ivorian network there have developed camps, prayer camps, where they are targeting interfaith-based people, ranging from Christians and Muslims, and as a result of this, this information is reaching to the congregation. In South Africa, also in the community setting, we are addressing internalized stigma, and they're using lessons learned from the community to household settings and raising funds to the National AIDS Council through the Global Fund as the principal recipient to advocate for the national rollout of their Stigma 2.0 in about 6 provinces. Next slide. So what are the steps to join Global Partnership? Step number 1, do your stigma index. This will enable you to identify the areas in which stigma and discrimination is prevalent in your country. And we can work together so that then you are able to identify a priority setting amongst the 6 settings that I mentioned. This can be done through country consultations with civil society. And in those consultations, we urge you to be as inclusive as possible and include communities of people left behind, such as key populations, gay men and other men who have sex with men, LGBTIQ communities, sex workers, communities of drug users, communities of people living with HIV, working with your UN partners and your donors in the country to enable you address the gaps and inform the policy and use the data that is generated from Stigma Index to drive your interventions. Additionally, your multi-stakeholder approach will enable you to champion and advocate for domestic resourcing at a country level. One of the key things that the Global Partnership advocates for is that in as much as we would rely from external funding, we also urge countries to contribute in towards addressing stigma and discrimination at a local level. So domestic resourcing is very important. Next slide. What are the ways that we can work together? We have a number of tools that we have developed. We have an advocate's guide that gives you a step by step on how you can implement global partnership. And you can always reach out to GMP Plus and we can work together and provide technical assistance. We are also being very um, deliberate in addressing gender transformative approaches in global partnership. This can also be found in our M&E guides. We are looking at an impact. Global partnership is impact based. So we are focused and working at country level and working with communities at country level to then translate those interventions into action at a country level. And in turn, we'll be able to see an overturn of and a reduction of stigma and discrimination in different countries. At GMP Plus, we have worked with multiple stakeholders, and this is where we encourage collaboration amongst our key partners. We are working with Beyond Stigma Ireland, IAS, Dutch AIDS Life, Love Alliance, CDC, PEPFAR, UNAIDS, just to mention but a few. All these collaborators come together under the red ribbon for the 10-10-10 targets. Next slide. There are many ways of engaging with us. We would urge you to join the different campaigns that we have under the Global Partnership umbrella, particularly the campaign that we are calling Not a Criminal. This campaign is about communities and communities who are marginalized and criminalized on a daily basis and continue to face stigma and discrimination. We urge you to join the Not a Criminal campaign by visiting our website, and we can engage and we can find ways of working together. But we also look at specific days that we can highlight. We are working on days such as Zero Stigma Day and HIV is Not a Criminal Day, World Humanitarian Day for the humanitarian settings, and International Workers' Day for the workplace settings. These are all opportunities that we can all engage, even though your communities or your countries may not be partners in the global partnership, even if your countries have not signed up for global partnership. We can work together and with the minimal efforts of advocacy, we can begin to push our countries to join global partnership. Next slide. Next slide. I will go to the next slide because I already talked about this. Slide number 12, please. I can't see. Yes. Oh, I actually talked about this already, about communities and women and the advocacy. I would like to end there. Thank you.
Thank you, Dottie. Thank you for those very practical examples and offering a practical approach on how to address stigma and discrimination, utilizing the tools that have been developed by partners, but also utilizing the data that Omar spoke about earlier. So our last speaker, Sibongile, is going to now talk about the global consensus on HIV, stigma, and discrimination. Thanks.
Good afternoon, and I just want to start with just applauding the communities for the Global Stigma Index report. Can you please give all the communities a round of applause for the amount of work that they've put into that research, and really just want to say thank you to the Stigma Index team for working so hard to produce this global report. It's a piece of paper that's important for our advocacy, not advocacy in countries, but also our global advocacy. And I'm just going to present the work that we were doing with the International AIDS Society, IAS. And I'm just going to give you a background. So can I have my slides on? So I'm just going to give you a background. So when IAS came to us, they had this idea of building a global consensus statement on an HIV-related stigma. And we were really, really excited as a global network because this was the first time that a global consensus statement was going to bring different players. It was the global network, but also academics, but also the global institutions such as UNAIDS representative. And when we came in together, I think as a global network, one of the things we were not expecting was to build a global consensus statement on definitions. I must say, this process took us 2 years. And I want to just highlight that there was such an important lesson around collaboration, but also when we talk about multi-sectoral approach, that when we are all coming from different approach, from different sectors, we are all looking at things at a different approach. So on our side, when we were meeting as a team to actually with the different authors, when we were coming up, when we were thinking around the global statement, was one of the things from the researchers was that there was a steering, there was a review that was done before the global consensus statement that actually showcased that researchers and health practitioners did not have a standardized definition of stigma related of HIV stigma related approaches. And we were quite shocked because we've been working on the stigma index for so long, and we did not want to now start thinking about definitions. And so it was such a long process of around how do we come together and build a consensus on definitions, on approaches, and also on a call to action. So I'm just going to take you through that process that we worked on. And as I said, the background was really that all of us identify that HIV-related stigma is a significant barrier to HIV prevention, treatment, and care. But most importantly, also, it's a barrier to, also we understand that for us to actually, we need to understand HIV stigma for building public perceptions, but also for policy purposes. So as I said, on our side, we didn't understand that there was a lack of consensus about the HIV-related stigmas and domains. And again, from a research point of view, it was creating challenges and inconsistency among different frameworks and measures. So this global consensus statement was really, really trying to achieve a precise definition. No, it was trying to achieve whether can we agree that we actually need a precise definition on HIV-related stigma types, and and impact is essential for guiding HIV service and policy actions. So we went through a process called the Delphi process. And the Delphi process brought about 50 global experts. And these were coming together to share insights and knowledge through a questionnaire. And I'm just going to share some of the findings from the questionnaire. And the panel reached a consensus on 55 out of the 100 points across 12 themes. In round one, so we had two sets of rounds. In round one, 93 questions achieved consensus of 70 to 100%. And of these, 44 reached consensus of 98 to 90 to 90 from 90 on 98 to 100%. Of the one potential consensus points that reached 95 to 97% agreement in round one were present in round two, and the 11 points generated consensus of between 97 and 100 were included in the final consensus statement. So just to give you who are the experts in both round one and two. As a global network, you would know we would push mostly for civil society. So we had 46% of the respondents were from civil society. 39% were from the academia, and 0% were actually from the clinical practice, and mostly were divided between the donors and policymakers. And even in round two, the same, this 47%, and and then others were actually divided amongst law, nonprofit research institutions, academia, and civil society. So now I'm just going to go into the 5 consensus points across that were agreed across the 12 broad themes. Number 1, the importance of addressing HIV-related stigma at scale. So the respondents noted that it's important to understand that how stigma and discrimination are experienced, and that also it is important to measure stigma in a systematic and throughout manner in order to reach the global consensus state, the global HIV state targets. The second point was around the HIV-related stigma and definitions, and the and the and the and the respondents also agreed that it's also important that we do reach a consensus on definition and the use of stigma-related languages. I also just want to highlight, so there's there were 12 themes, but I just want to also highlight 2 key ones that were quite important for us. One was the community leadership in HIV-related stigma reduction and implementation. The experts agreed that a combined community-led approach of providing education, counseling, facilitating access to an HIV specialist, and engaging a support person should be scaled up globally within stigma reduction programming, and this was reached at 100% consensus. It is important that community-led approaches are well documented, and that standard reporting guidelines should be developed on community engagement in HIV-related stigma and stigma reduction and implementation. And so and the last one is around just looking at the knowledge gaps and the research needs. One important point was around it is important that investment is made to establish a robust evidence base across range of settings and diverse populations of promising interventions and processes to support stigma reduction. There is a need to develop and evaluate more diverse approaches to the effectiveness of stigma and discrimination reduction efforts. More community-led research is needed about and for diverse community of people living with and affected by HIV, including young people in low and middle income countries. Efforts should be stepped up to strengthen the evidence and the knowledge base on stigma and discrimination in law and policy. And then another one is stigma reduction efforts globally would be better served by including broader outcomes such as well-being, mental health, and quality of life. Research is also needed to inform the knowledge gap on the measurement and the evaluation of effectiveness to address internalized stigma. And lastly, it is important that research to be conducted to provide data to support future funding and investment in the larger number of societal enabling approaches that have been piloted and found positively influence the effectiveness of HIV services. So the global consensus statement also had a call to action, and really the acknowledgement of the following points were addressed in the statement, that addressing HIV-related stigma is important at scale, moving beyond an individual and facility interventions. And we saw from the stigma index report the same findings. Achieving a consensus on definition and the use of stigma-related language is important. And I'm just going to move to the second call to action, because this was about communities. The biggest thing was around acknowledging that communities of people living with HIV in their diversity are at the center of anti-stigma efforts and must be sustainably and accurately resourced by other stakeholders to lead in. This call to action was written for the policymakers, the researchers, the donors, and it includes monitoring, reporting, and publishing research by and for the diverse of communities of people living with HIV, including young people, on their experience of HIV-related stigma. And advocating, we ask that they advocate for the increased funding, attention by government, donors, international organizations, and researchers to increase monitoring and of response of stigma and discrimination and human violations. Steering the design, development, and implementation of stigma research projects that are led by non-community actors, documenting community-led approaches to stigma measurements and interventions for learning, adaptation, and application in other contexts. So our call to action, another call to action was for our researchers, again, for the policymakers and the implementers, is that we would like you to engage with the consensus statement so that you commit to specific actions. And specifically, lastly, I just want to say we call on all countries and their cross-sectoral leadership to make concerted efforts to achieving the UNAIDS 95-95 targets for HIV testing, treatment, and viral suppression by 2023, by 2030, and committing to addressing HIV-related stigma and removing societal and legal impediments to HIV. Committing to specific goals such as removing legal environments that impaired HIV services and ensuring that more than 10% of people living with HIV and people in key population experience stigma and discrimination. Again, invest in societal enabling approaches that remove the legal barriers. And lastly, remove or update the laws that fuel the stigma and the impediment of HIV services. So thank you so much. So this is the global consensus statement that GNP Plus and IAS and UNAIDS and other, and I'd really like to thank IAS for really getting us together to build a global consensus statement that can be a pathway on how to we together work on HIV stigma and discrimination related interventions. Thank you.
Thank you so much, Sibongile. So I think we have a little bit of time for some questions. Do we have the roving mics? We have one question here, one question down there. Do we have the mics? Do you want to just project? Yeah.
Go. Thank you. We have a long way to go to really look at the evidence-based programs that support people to deal with internalized stigma. So I guess my question is, you know that we've been working here and we're so proud to be working with Jvandiri. My colleagues are here today in the Wakakosha program. Young people, would you like to stand up? Just let everybody see you. Wakakosha guys. These are the people who know what's needed, who knows what we need to do. And I guess my question to you guys is, if 84% of people are still experiencing internalized stigma, why are we not investing more in this? Why have we not got more investment? What can we do for the likes of UNAIDS is such a good supporter, the Global Fund, some of the big funding mechanisms, Robert Carr. How can we harness some of the funding mechanisms to direct funding in this way? And I'm just so grateful for the global partnership. So that's my question. How do we get more emphasis, more funding and more support for this? Thank you.
Thank you, Nadine, and
The-
thanks for your comments.
The second question from here, my name is Peter. It's a follow-up of the same question on the 84% self-stigma. So the first question goes probably they may not be able to answer, but from Botswana, we have seen, I think they are doing very good in terms of 95, 95, 95 target. What's their country stigma index? I believe probably it has gone down. The second question is, when we are talking about that numbers, we are talking about patient, we are talking about people. The number speaks about people, they speak about the patient themselves with HIV. One of the causes of stigma or after stigma, they normally have the depression or the anxiety. When we are doing the study or when we are conducting, especially for the self-stigma. For the depression, probably when you're doing the screening for them, because most of those patients probably you'll find they are either depressed or they have the anxiety. So apart from collecting the data, in terms of the patient, they need probably the commodity. What are we doing? Are we linking them to the counselors, psychologists, or the caregivers? Probably for that, for the mental health aspect that causes the stigma, the self-stigma. Or are we just collecting the data and we are just going without the intervention? So what
Thank
are we
you.
doing for the intervention?
Thank
Because
you
now
for your
the
question.
number speaks about the patient.
Thank you. We have one question down here.
Thank you very much for these excellent presentations and the fantastic work you're doing. We're many decades into the HIV epidemic, and it's a new world. We have fantastic treatment. We have really good access to testing, and we have U equals U. People with HIV can live happy lives and long lives and have successful relationships, have healthy children. What's happened to stigma over these decades? Why is it still so high? Is it improving? What have we done right, and what have we done wrong in the response to stigma?
Thank you so much. So we're going
Hello.
Let's take these three
I can
questions
speak.
first. I'll ask Dottie to take the first question on internalized stigma. There was also the question on depression and anxiety and service linkage. And then the question about Botswana's stigma index, Omar. And then the final question, Spongile, to you on what we've got right on addressing stigma and what we still have to do.
Thanks, Omanyana. So really around internalized stigma, when it does come to the global partnership, and this is why I think GMP Plus is particularly invested in supporting countries in implementing activities at a country level. So the work that is done by organizations such as NAP Plus Ghana are quite important because we need to, and we are actually doing it, we are capturing the impact stories and wanting to share this across the countries and make sure that that is replicated. And I think my answer goes to Peter as well, is the data, yes, is gathered. And we know that there is stigma and discrimination that exists within healthcare settings. What we are aiming to do, again, also through global partnership, is to really advocate that we need to be able to eliminate stigma and discrimination within the healthcare setting. And how do we do that? And so that's the work that we are supporting and we are investing in as GNP Plus to work with the national networks in country, because that is where the action needs to happen. That because the countries are the ones that are signing on, that are committed to addressing stigma and discrimination. So investing in national networks of people living with HIV and working with them to find solutions that best work from them for them, and then replicate that and share those as best practices.
Uh, Thank you very much for the question. Uh, can you hear me?
We.
Uh, yeah, I'll use this one. So Botswana was in the process of implementing the stigma index in their country when we start the development of this global report. So the data from Botswana was not included because it wasn't available at the right time. I think when it, but I'm quite sure that right now they're completed the process, and if you need to have access to the report from Botswana, you can always reach out to us, or you can feel free to reach out to Bonepa, who's leading the implementation. Bonepa is the PLHF network in Botswana that's leading the implementation of stigma index in their respective country. In addition to Nadine's question, hi Nadine, very happy to see you. And I think this is exactly what we're trying to do, producing more evidence, data that we can use to push and to direct investment to where it's supposed to go. And I do agree with you that internalized stigma is something that actually is a lower hanging fruit. And this is coming from my life experience. Like, to me, when I want to change the people around me, I better change myself first. That's, I think, how it works, and it works well for me. So to me, and this is again related to the last question on what we do right and what we have not do enough. I do think when we talk about tackling stigma and discrimination, we're mostly spending a lot of time, resources to educate people, to train healthcare workers. Yes, it is important, but it's not enough because knowledge does not translate directly to belief. What drives stigma and discrimination is belief. It's not only knowledge, but it's also belief. We see a lot of well-educated people still stigmatizing, still discriminating people with HIV and marginalized population. And we have to understand stigma comes from rooted from a social norm, religious values that has been existing for millennia. So you can't really change that in 20, 30 years. And we have to really understand that. So to me, while we work on addressing externalized stigma, there's actually a lower hanging fruit that we can do by capacitating PLHIV community, let them know what their rights, make them confident, and make them able to live their life with HIV. Thank you.
I think Omar has like really touched on so much, but I do think, just to add on what Omar was saying, was that obviously when we look at the history of like the HIV programming has always, even now, really, it's about treatment. I remember when I got infected with HIV and I went to the clinic, and it was, and I was told about the medicine more than, I mean, the adherence clubs were no longer there. Oma, I'm more the, the younger generation of HIV. The adherence clubs were not there. I was just told, you're going to take the pill and you just move on. But then I was never told about the shame of how I got HIV. We get HIV through sex, and sex has a lot to do with some of us got it through sex, some of us are born with it, and that has a lot of societal connotations to it that the HIV programming and even has not looked into it. So I think so much emphasis has been placed on treatment over the years, and I think even now we are seeing what happens when we don't when health interventions are not human-centered, but they're more focused on the science and the science around the disease. So I think the reason why we're here now is that we are seeing that HIV is a human experience, and to have a human experience means there's the science, but there's the social, the economic. I mean, last week I was at Women Now, and I went to a panel of young people living with HIV, and the one thing that they said, they are leaving the healthcare setting because they said, when I go into the clinic, I am reminded of the disease. I am not reminded of who I am. So as we think around HIV program, I think Florence has left, my co-ED always says, they need to stop seeing us as disease, but as humans. And what does it look like as a person living with HIV? What are some of the barriers? And we need to integrate all of that into our HIV programming moving forward.
Thank you so much to all of you. Was there a final question or can we close? Okay, that's.
Oui.
Oh, no.
I speak French. Voilà.
Can,
Donc,
can
je
we
tenais à
have
vraiment vous remercier.
can we have an interpreter?
Je me nomme Semi Loubertine, je viens de la Côte d'Ivoire. Je suis la présidente de la coalition des
Pardon,
organisations.
pardon, pardon.
OK. Je suis la présidente du réseau des femmes vivant avec le VIH en Côte d'Ivoire. Je viens de voir la présentation du directeur et dans lequel j'ai eu l'information qu'il finance la Côte d'Ivoire. Donc, je voudrais savoir quels sont les critères de sélection pour financer les structures dans les pays. Et au niveau de la Côte d'Ivoire, je n'ai jamais entendu parler. Il fallait que je vienne ici pour avoir l'information. Donc, je voulais aussi inciter GNP+, à demander aux organisations qu'ils financent de faire leur promotion. Parce que là, nous, on a été surpris de savoir que c'est ACIP qui est financé au niveau de la Côte d'Ivoire. Merci.
Merci. Can we get the translation?
Hi. So I'm going to try to interpret, and hopefully I'm not going to miss anything in the process. I'm Marlène Bras from VIS. So this lovely woman wanted to know what was the process basically to be included and to receive funding and sponsoring. And she mentioned that coming here was the first time she was hearing that Côte d'Ivoire had data and that she was not aware of that. So how could the information be shared, and how could various countries be part of programs that are funded or interventions that are funded by TNP+. Thanks.
Thank you. And thank you for stepping in with the interpretation. Dr. Omar, you can go ahead. Thank you.
Thanks for the question, and also colleagues, thanks for help for the translation. Ivory Coast is one of the country where their data were included in our global report, and in the process of stigma index implementation, there has to be one leading network. That doesn't mean we don't want to involve other network, including women living with HIV network, uh, young people living with HIV network. They all should come together. But in most cases, it was the national PLHIV network who lead the implementation. But in many cases as well, those other networks are, working together and support the implementation process. I think in a sense of partnership, there's always room to improve, and we acknowledge this. We recognize that sometimes in a country there's tension between networks. That's something that I feel like we should acknowledge, because we see that it's an issue that we have to tackle together. And but I do urge you to reach out to the PLHIV national network in Cote d'Ivoire. And we're happy, GNP Plus, we're happy to facilitate how the women's living with HIV group in Cote d'Ivoire can, work closely with the PLHIV group there. Because at global level, we work together with ICW in Stigma Index program. They are very important partners in our process. So we really feel that should also be happen at country level. Thank you.
Merci beaucoup.
Merci pour votre question. And thank you all. Thank you for, we have one more question here. we'll take it because we're taking liberties with this time that we've been given. Please pass the mic.
My name is Houssine El Rilami, University United Morocco. My question, thank you for your presentation. And my question, as you know, for my friend Omar, my question is about, as you know, in Morocco we have conducted a very difficult stigma index 2.0, and they take us a lot of time to have this study. And unfortunately, it's not listed and the country where the stigma index 2 conducted. Thank you.
Thanks so much, Hussein. I'm very happy to see you here. My colleagues, Hussein is really, a supportive partner for our implementation in Morocco. And the reason we don't have Morocco data is because when we start, Morocco haven't fully completed the report, and that's why we don't include the data sets from Morocco. But this is the first ever global report, and I feel like we will be able to include more data sets from more countries in the next global report. This is not going to be the last global report, so rest assured that in the next one we will have Morocco data in that. And just to let you know that we're now in the process working together with the colleagues in Morocco to conduct advocacy work using stigma index data, and we count on your support to for the process. So thank you for that.
Thank you. One more question here.
Thank you so much, the presenters. My name is Anton Sebastian Charles from Tanzania. I'm working in the HIV drug resistance unit in the molecular lab. I experienced the challenge of children which undergo the HIV drug resistance. I think I impose you as a challenge to work to those mothers with children living with HIV to facilitate or to have the care and treatment services to their children, because we are seeing there is the increase in HIV drug resistance to those children. And we know that children are the future generation. So I impose this challenge to the group of network living with HIV. Thank you.
Thank you so much for that comment and challenge to GNP Plus. Dottie spoke about the example of the work being done in Uganda, where women have been trained on these very issues and have become peer educators, and that program can be replicated elsewhere. Do we have one more question here? No. Okay. Going. We're well over time, and I want to thank you all for your engagement this afternoon. This is such a critical issue in the HIV response. We all know how important it is, and how important it is for each individual person living with HIV that we do the work of addressing stigma and discrimination, as well as for key populations and a vast array of people who will experience in their lifetimes this kind of stigma and discrimination. Nadine's point about 84% of people having self-stigma and feeling shame. These are issues that we all need to take on and that are part of the work that GNP Plus is doing, that they're leading on globally and at country level. Please speak to any of them. If you're interested in the global partnership, speak to Dottie or myself, and we will engage with you. Also, please follow GNP Plus's social media. Their campaigns on Not a Criminal are very exciting and engaging, and can be done at a country level with the data that Omar presented to individualize and contextualize for each country. So I want to thank you all, and thanks to the panel. One more round of applause for GNP Plus. We're now closed. Thank you.
I just wanted to say that tomorrow is Global Partnership Day at ICASA. So kindly visit the community village We will have a video screening on global partnership, and we will have lots of reading materials available for you to learn more about global partnership, and we can engage more, and you can meet the incredible team from Jean Diri that are working on Beyond Stigma, and we'll give them a platform to also share the work that they're doing. So we'll see you tomorrow. We also have a human rights session, also led by Global Partnership, that will be happening here tomorrow in the afternoon, and we'll share our details in our social medias. Thank you.
Last announcement for those who want to see the full report. There's a QR code in the banner in front of you. If you scan that QR code, it'll take you right to the full report. Thank you so much.
Thank you. Thank you so much, Mariana. Thank you. Thank you.
You see, you need to prep.
Thanks.
No, what time are we going?
Thank you so much.
Yeah, thanks. You want to take a picture?
Sure.
Sorry?
Announcement. Can you please leave the headsets at the entrance? You are reminded to leave all the headsets at the entrances. Thank you.
Please listen very, very attentively. For those who have our translators, you can drop by all the doors. Thank you. Please listen very, very attentively. For those who have our translators, please you can drop by the door. Thank you.
Please, let's not go out with the headsets.
Thank you. Merci.
Oh, dear.
Yeah, see.
I'm supposed to speak with you. Umetokea wapi? Okay, great. Thank you.